I'm Steph.
I'm Lisa.
And together we're PD Connect.
Connect.
Thanks for joining us today. We have Kimball Magoni here. I'm going to go ahead and intro you, and then
we are very excited to hear his talk, which was
Absolutely.
called Unbreakable, the self-acceptance mindset.
I cannot wait. All right. Kimball Magoni, PhD, is a licensed psychologist and a nationally certified health service provider in psychology. He has over 35 years of experience in private practice, treating adolescents, adults, and families. Dr. Magoni has a specialty in resolving many treatment-resistant conditions. He empowers his patients to discover and integrate effective coping strategies to address physical and emotional challenges. He is also a person with Parkinson's who enjoys sharing his journey through lectures and workshops on the role of resilience and Parkinson's disease. Dr. Magoni received his PhD in counseling psychology at Temple University. He completed a 4-year postdoctoral program at the Philadelphia School of Psychoanalysis, structural family therapy at the Philadelphia Child Guidance Clinic, and cognitive behavioral therapy training at the Beck Institute. All right, what a mouthful, but great, awesome. So happy to have you here. And
thank you.
Welcome.
Welcome.
It's great to be here. Really wonderful. Well, welcome everybody. Wonderful to be here with you. And I'm going to be talking about the topic of shame, which gets no attention because it's so taboo, but it's so important for us to talk about it and think about it and find our way through it. The title I chose for the workshop is called Unbreakable, the Self-Accepting Mindset, because I believe we truly have a choice and an opportunity to manage our shame responses. We can alter our experiences of shame, and we can choose to be resilient in the face of shame. Self-acceptance is not resignation. Self-acceptance is a really huge concept and a very important mindset. The idea is that it's a very active, choosing sort of paradigm. And it takes us being very conscious of our emotional world and making self-aware choices. I'm going to read you a bit of a blog by Angelo Angulo, who's a top researcher and really opened up the field a couple of years ago with his paper on Parkinson's and shame. And there's a quote, there's a blog that is really wonderful that gets at this topic. Acceptance is an active proposition or practice. We do not simply accept or reject. Acceptance is nuanced, qualified. We accept that there are things we can change and things we cannot. The discerning is not invariably easy to affect, but the distinction there is a distinction that makes a real difference, one that propels us to end passivity and embark in positive attitudinal mind changes. Recall that we are affected by PD, we are not defined by PD. Acceptance is not resignation, but the embracing of life as it is in this present reality. Painful as that acceptance may be, it's the firm footing for positive change to unfold. Okay, what I thought we'd do is I'm going to go through the slides and then we'll have a discussion. Whatever questions and thoughts and reactions you have, we'll process them and share them. This is called the piñata of adulthood. My point here is sometimes you're the stick and sometimes you're the piñata. The agenda we have for the talk is I'm going to define what shame is. I'm going to talk about the research about that. I'm going to talk about shame versus guilt. I'm going to talk about culture and adaptation. The person with Parkinson's, PWP, and shame research. It's very recent. It's the last couple years. I'm going to go over briefly the SPARK questionnaire, which Dr. Angulo, who's a psychologist in PWP, he developed this questionnaire, and we're going to take a look at that because it gives you a tool to take a look at your own relationship to shame. I'm going to talk about the good news, and I'm going to talk about building connections to self and others. Interpersonal connection is the antidote to shame.
Dr. Magoni, is it possible for you to make your slides a little bit bigger? So if you hit the green button where it says play by the slideshow up at the very top to the far right, it'll make your slides a little bit bigger for everyone to see.
Yeah, right there and then down.
Come down a little bit with your cursor and click that play button.
Yep. There you
Wow.
go.
Perfect.
Yeah.
Thank you.
And then to advance, you either press the arrow, the next arrow, or sometimes I think you can even press the space bar.
Yes.
Oh, okay. Great.
Great.
We'll get this down. This is great. 21st century, getting close. Okay, so the agenda I went over. This is the definition of shame. Shame is an intensely painful feeling or experience of believing we are flawed and unworthy of love and belonging and deserve contempt. We feel shame when we believe we have violated an important social norm. Shame is characterized by feelings of powerlessness and marked by a desire to disappear. The cycle of shame is characterized by secrecy, silence, and an internal attack of the self. Shame is a threat to one's well-being. There are two types of shame, internal and external. Internal shame describes the self-evaluation a person applies to himself or herself. External shame relates to the perception that others are judging one negatively. Projection involves attributing to others one's self-perception. There is an abundance of psychological research on shame and embarrassment in the general population, but a dearth of literature regarding the topic of shame in people with Parkinson's. What's important to note is not everyone experiences shame equally. There's a distinction between individuals who experience occasional in-the-moment shame, right, situational, and those who are shame-prone. Shame proneness is linked to higher rates of depression and social anxiety. There is individual variability with regard to levels of self-awareness about shame, personality traits such as harm avoidance, which is basically a social generalized anxiousness, level of self-esteem, and family and cultural influences. In some families, shame is minimal. In other families, shame is very pervasive. So that just colors our present experience. If we're feeling shame about our symptoms in Parkinson's, or if we're feeling shame about, the idea that we feel like we're outside the social norm, it's important to know that that really varies. The topic of shame is a taboo subject in the culture at large. The subject is typically avoided in clinical, non-clinical settings. I was diagnosed 9 years ago, and I remember my first clinical experience, and I don't know if anybody else went through that, but it was very difficult because the doctors were very well-meaning, but they weren't attuned as much to the emotional relationship context of which the diagnosis was being made. So it was all about a list of what you can't do and not about all the possible, what the research shows now, that we have a whole variety, a plethora of things that we can do on a daily basis that make a huge impact. Oh, okay. Shame is evidenced as early as 18 months of age. So even infants show through their body posture, the head going down, the shoulders dropping, the color in the face and the skin, that they've been able to track shame that early. Next, please. What do you think's happening there? Isn't that interesting? The woman is in front of a crowd. She's done some kind of performance or speech, and everybody is, you can see her clapping and all excited. And there's one person with a disgruntled look, and she focuses on that and says, "They hated me," right? That's a shame-based response, right? What she's doing is, it's called projection. She's afraid of being not good enough, and she transferred that to the one person who looked disgruntled and made an assumption that he was down on her. Now, the cognitive behavioral technique that one would employ here, it's a cognitive behavior therapy, is a type of therapy that helps us deal with our assumptions. The assumption she's making is that he's going to be down on her. So she finds that one person and selectively doesn't see all the other people who are excited about what she's doing. So we tend to project our insecurity about our symptom picture and assume everybody is, or many people are down on us, when once we really examine it, this fellow may be upset about his mortgage payment. I mean, it could be 100 things that he's disgruntled about, but her anxiety about being seen is what really made her attribute to the one person the conclusion that she had assumed. Next, please. Shame versus guilt and embarrassment. Shame arises when one becomes aware of a so-called perceived transgression, then one concludes that they are fundamentally flawed and worthless. Guilt is characterized by a self-appraisal confined to limited behavioral aspects of oneself. So you all, one thing, a good example of this is I am bad, which would be shame, a global self-attack, versus I did something bad, which is a specific behavior that is capable of being remediated. I am a mistake versus I made a mistake. Another good example. And compared to shame and guilt, embarrassment is associated with one's social reputation rather than a concern for others' well-being and a need to make amends, as in guilt, or with a concern for oneself with a need to hide, as in shame. With shame, the action tendency is to escape, disappear, and isolate from the self and others, from the self and others. And it's accompanied by a drop in mood and self-directed anger. With guilt, the action tendency is to make things better by confessing or apologizing, hence feeling better about the self. And you have a very interpersonal experience of shame and of guilt and reparation. And with shame, it's a tendency to turn inside, to want to disappear, to want to be smaller, and remove oneself from the interactive field. And so for us, when we're dealing with our Parkinson's symptoms and our Parkinson's treatment, we go from the initial diagnosis to, we go through a process that we have to go through to access our feelings, deal with our mourning and grief over the initial diagnosis and all our fears about that. And then we have to work through to get to a place where we can accept our situation and then actively do what we need to do to affect change. Next, please. In relationship to empathy, shame and guilt have different relationship to empathy. Guilt is associated to other-oriented empathy, right? I've hurt someone's feelings by something I said. I have an empathy to them, and I want to make it better. Shame's connection to empathy appears to be disrupted and focuses on self-oriented distress. And you can see in the movie theater, there's quite a showing we've got on the screens. We've got the Neuroplex movie theater, and what's showing on screen 1 is my insecurities. On screen 2 is my inner guilt. On screen 3 is my self-loathing, which is to be the shame. And on screen 4 is my parents, which figures, right? Okay, next slide, please. Shame is adaptation. There's an evolutionary value to all emotions. Joy, sadness, jealousy, guilt, anger, disgust, shame. In other words, all these emotions that we experience have evolved over the millennium because we need that to survive and to adjust to our circumstance to be able to thrive and survive. People are wired to fear illness and disease. That's part of when we see the reactions that people have at times to our Parkinson's symptoms. It's similar to the idea that people are afraid of what they don't understand. So it may appear that they're being critical, but most of the time, people are just surprised and withdraw a little bit because it's an old unconscious evolved wiring that you try to avoid any illness. Kleck studied at Dartmouth found that in the presence of amputees, able-bodied people stood at a greater than customary distance and manifested symptoms of panic. Shame activation is viewed as an alert that one may be exiled from the community, born with the knowledge that our lives depend on acceptance from the tribe. So you can see how this evolved, right? If somebody committed a behavior in the tribe and it was a threat to the group, that person would be shamed. And that would be a message. The good news is that would be a message to the individual that they need to reorganize themselves to get back into the tribe. And frequently what that is for us is that we have to come to grips with our illness, grieve and mourn what was, and then move into our new space and take on the challenge that is what Viktor Frankl calls traumatic empathy. Shame activation is an alert. Next, please. Shame of perceived weakness, having physical and emotional needs. Shame in American culture. We worry about perceived weakness. Having physical emotional needs is not something that's welcomed in American culture by and large. The market-driven culture emphasizes rugged individualism by the history and results in overfocus on personal and social perfectionism and performance. The nation's religious history early on with the immigration of the 1600s contribute to austere self-discipline and focus on achievement. Examples in our culture, they've done studies that found that people frequently get 2 weeks vacation and they don't take it. Right? There's a shame. It's like to be kind of the ultimate individual, rugged individualist. You don't have needs to be taken care of. You don't have needs for time off, vacation time. Then there's also weight shaming, online shaming, competition on social media. This results in an inhibition of diversity and appreciations for differences. And the fact that everybody at one point in their life is going to be, if not many times, but one point ultimately where they're going to get sick and have health issues. And it's really tough to get validated in the culture when youth is really highly supported by the goods and services. Medical culture is characterized by lack of time with doctorate visits overall, and an overall depersonalized experience. We all have personal stories. Doctors frequently ignore emotional needs and report what the patient can do no longer versus specific paths to wellness. Lack of training in med school often leads to shaming experiences. It's really interesting. When I first recruited the treatment team that I was looking for, I went through a few doctors for the fact that I wanted somebody who was going to be a healer. And what I mean by that is somebody who has good emotional IQ, who can really connect with me and make me feel like my whole self is there, not just my PD symptoms. In other words, I have an illness, but I'm not identified completely with my illness. I'm who I am, plus I have an illness. And the doctors that I ended up with really I was very selective about that. That was part of my acceptance journey, was to pick a team that I knew had the emotional chops to really offer me a relationship. And that would provide a context to look at the symptoms and look at the illness. So we have to be aware that there's a shame factor in American culture, and we have to just mediate that in our own minds and know what the right things are about what, shame. Everybody has shame, because some people hide it better, but everybody has shame because it's an evolutionary warning sign letting us know that we're feeling like we're outside the norm, outside the tribe. Next, please. Well, there you go. There's the cultural piece. Next, please. Shame and Parkinson's disease. This is a study by Angelo Angulo and Associates. And the study included 44 persons with Parkinson's ages 60 to 75 with an average diagnosis of 5 years. The PD-related shame was discovered to emerge from the following sources. Number 1, motor symptoms: hand tremors, modified speech, unsteady gait, small writing, facial masking, dyskinesia. Number 2, non-motor symptoms: dysphoric body image, excessive salivation, slowing of thinking, memory issues, depression, anxiety, social withdrawal. Number 3, changes in level of independence. Number 4, breaking of social norms and rules, assuming one is breaking the rules of competence and usefulness. Number 5, changes in body image, disruption of self-image, the body no longer representing who one is, the feelings of disconnection from self, feeling seen as old, and as if that's a bad thing. That's shame. That was found, those aspects of functioning were found to be associated with shame to certain numbers of people who are PWP. Next, please. The consequences of shame on PWP quality of life, the Angelo study continued. Many PWP reported feeling disempowered and negatively judged. Most PWP rate their emotions as intense, especially early in the process of Parkinson's. Parkinson's UK studies, 41% had some form of discrimination during their illness. There's increased anxiety and depression associated with shame. There's a tendency to dissimulate, to hide and avoid symptoms and social encounters. PWP do not usually discuss shame. Physicians rarely broach the subject of shame, which reinforces PWP shame and secrecy, lack of training and awareness of shame research. I'll just tell you really quickly, I had a really great physician that I was working with, but he had no understanding or knowledge about shame and emotional kind of issues in Parkinson's. And I shared Angelo's study with him, and he was fascinated by it. And it was so great because I've had a few doctors that I've shared a lot of research done by Dr. Laurie Mishley about the amazing effects of food and diet, nutrition, exercise, sleep, making your sleep good shape, social connection, the number one item associated with progression, according to Michelle's studies, it includes social isolation. So it's really important to expand our awareness and help other people, expand their awareness that are working with us. And I find that I share my research with the doctors I see, and it has a good effect. Next, please. Spark is a 5-minute questionnaire, 5-minute self-administered questionnaire. It just came out in 2020. It's a 33-item questionnaire, and it's really the first tool to address Parkinson's and shame by reinforcing curiosity and self-awareness. There's a significant correlation between Spark scores and increased depression and anxiety. So shame factors in, and it's something that we talk about because it's really important to kind of enter that into our equation. Increased Spark scores are correlated with diminished reported quality of life. Embarrassment reported by 85% of PWP. Shame reported in 26% and 15% reported in neither. This is the first big study investigating a questionnaire. Shame and embarrassment varied upon level of self-awareness, the personality trait of harm avoidance, again, social anxiousness, self-esteem level, and cultural factors. Here's the most important thing. No relationship was found between PWP shame, level of shame, and the duration of PD and the severity of motor symptoms. No relationship found. So one might assume that our shame would grow with our increased severity of motor symptoms as the condition progressed. In reality, the research demonstrates that our shame is an issue that exists outside of the duration or severity of the Parkinson's symptoms. We have the amount of shame we have regardless of the symptoms we feel ashamed of. So it opens up the whole area that, just like resiliency research shows, that you can have progression and long duration, and it's not correlated with decrease in resiliency. Actually, you can have an increase in resiliency and an increase in reduced shame. You can have reduced shame, and the symptoms duration and the severity don't determine that. So it's up to us to acknowledge it, work with it, and share with each other about our shame stories. If you want to find the questionnaire, you can just Google Spark questionnaire Parkinson's. You'll find the first result that comes up will give you the questionnaire, and you can take it and see what you think, if it's helpful to you. I'll give you a couple of the items on the questionnaire just to give you an idea. One of them is, I feel embarrassed or ashamed due to Parkinson's because of my visible symptoms such as tremor. And it's like a little bit, some, a lot, a whole lot, right? That's what the way you endorse it. And I feel embarrassed or ashamed because of my non-motor symptoms, such as oversensitivity to my emotions, with memory reduced and motivation reduced. So that gives you an idea of the symptoms. And even though my symptoms have increased over a bit over the 9 years, my feelings of shame have actually more significantly decreased. Next slide, please. This is just a quick view of the questionnaire, 5-minute questionnaire, and it's based on Angelo Angulo's innovative studies. And that's what you'll find if you look it up. You can play with that a little bit. What I did is next slide, please. What I did is I kind of retrospectively took my score, and I'll tell you about that in a second. But with the Spark questionnaire, shame and embarrassment contribute to alteration of self-identity, social anxiety, isolation, and depression. My scores, I did a retrospective review of my symptoms and my overall functioning with the questionnaire. In 2013, I came up with the score, which was about 30, and the average for PWP was 24. So I was really high. And it was really interesting to look at the items that I checked because it had to do with my anxiety about my tremor and my swallowing. And as I worked with counseling, and as I worked to correct self-talk, and as I worked through the initial diagnosis and did the grieving, the stages of grief, working through that, then I really became to disidentify PD as my primary identity. I increased my self-acceptance and involvement in PD group activities, including rock steady boxing and a whole lot of other things. But Hegel, the philosopher, said to be aware of limitations is already to be beyond them. So once we kind of work through our upset and our grief, and it comes and goes, but once we really let go of the need to not be who we are, right? And not, once we've accepted that our Parkinson's is what it is, then we're freed up from our grief, then we have the energy from the grief being resolved to really take on all the stuff that we can take on. And it includes, obviously, rock steady boxing, yoga, PT, OT, speech and language, community activity, volunteering, getting outside ourselves, joining support groups. We have a ton of choices. Next slide, please. I think the Abominable Snow Woman's a nice person. But she's got some shame going there. Okay, next slide, please. Oh, next slide. I'm going to go past this. This is too long. Next slide. Okay. The squirrels are having a discussion. Okay, next slide, please. PWP shame effect on the family. The initial shock of PD diagnosis and family response. It's interesting. I've done 30 years of family therapy, working with young kids from age 8 to in their 20s and their families. And I found that the family response follows the lead of the person who has the issue, right? Everybody's at the same level with it. So I know when my wife and I told my son about my diagnosis 9 years ago, it was really a very important moment because we were able to work that through just fine. And it makes it, the difference between facing it and dealing with it and not is really profound. Kids will really pick up. One thing I learned about treating children is kids will pick up everything that's going on in the family, whether it's ever uttered or identified or verbalized. They pick up on everything. And so what really is interesting, if a PWP in the family system isn't talking about it, then no one else can really talk about it. And then once they get support, whether through their support group, their PT group, their OT group, wherever they get their support, to really open up, releases the tension for everybody, and that it becomes not such a large item, but something that can be digested in the family system. There's a concept called intergenerational transmission of trauma. And the bottom line is, I think we all are aware of this, but when issues aren't dealt with in the present, they get passed down to the next generation. So the motivation is to help our families support, give them the support they need, and get the support for ourselves, and know that we've got a new venture that we have to all go for in a very determined way. Next slide, please. Personal skill building, building connection with others, PD community activities, supporting each other. There's PD summer school. It's a week-long summer school of intensive Parkinson's programming put on by Lori Mishley, Dr. Lori Mishley, and staff. Psychotherapy to address isolation and avoidance of social situations. Understanding your personal narrative and confronting faulty cognitions and assumptions. Learning to recognize and dispute your inner critic. We all have an inner critic, and it's an adaptive thing, because the inner critic is the part of us that says, okay, it's time to get up, your alarm went off, get moving, right? It's like we talk to ourselves constantly, whether we're aware of it or not. We're always talking to ourselves and giving ourselves direction or not. And it's important to understand your personal narrative, right? And confront the faulty assumptions. Sometimes they call this all or nothing thinking, like it's either this or this. I'll never be able to do this, or I always will be dealing with this. And that's catastrophic and all or nothing thinking. And learning to recognize and dispute the inner critic involves taking a look at those faulty cognitions. Pursuing physical exercise, nutrition, addressing sleep issues, building self-compassion and empathy. And that's really important, the self-compassion, because many of us drive ourselves very hard, and that includes working with our PD. And it's important to, with connection with other people, it helps build self-compassion and reduces shame. I could give you an example. I have, for the last basically 4 years, I've been a part of a Rocksteady boxing group. In the humor and connection, it's like any group evolves from one place to another place, right? When group members are first together in any kind of group, there's a kind of a, need to build trust. And then once that people talk and share, then what happens is they call it cohesion, group cohesion. The group undergoes transformation and all the members get transformed along with it. And the beauty of things like support groups, PT activity groups, whatever the group that's oriented towards Parkinson's, the value of that is just unbelievable, because we are building a shared social identity where we feel like we're outside the norm, right? We're the unhealthy ones, so to speak, and everybody else is going to a lot of times portrays themselves as everything's great, everybody, how you doing? Great. How are you? Great. Everything's great, and it's like, no, it's like tragic optimism, Viktor Frankl, right? True optimism isn't toxic positivity. True optimism is born out of dealing with tough circumstances, dealing with the reality of them, and saying yes to life anyway. That's what Viktor Frankl talks about, saying yes to life anyway. And he says that it's so interesting. He says there's the Statue of Liberty on the East Coast, the Statue of Liberty on the East Coast for freedom. He thinks there should be a statue on the West Coast that's for responsibility, right? That's kind of what he was talking about. And Viktor Frankl was a Austrian psychiatrist who spent 3 years in Auschwitz in the concentration camps and wrote a classic book called Man's Search for Meaning. And he has about 8 or 10 books that are really wonderful. Will to Meaning, The Doctor and the Soul. I mean, he's just a wonderful, wonderful writer. And he talks about the idea that no matter what our circumstances, we have a responsibility to affect change, and we can do that. Finding ways to get outside yourself, volunteering, assisting with people, assisting with PD support groups, etc. Grieve openly and live fully. Build a new mindset brick by brick with an increased sense of control. And the research shows that people who have an internal locus of control, and the internal locus of control is I decide what I'm going to do, and I decide what I can control and what I can't control, is very different than an external locus of control, which is everything happens to me and I'm like a leaf blowing in the wind, right? That's an external locus of control. But what's been shown in resiliency research with Parkinson's is that people who have an internal locus of control and work to affect that, if you don't have that, you work to affect that with your support groups and your counseling. And people who build an internal locus of control have less disability, no matter what the severity of the symptoms. Over time, they have less disability. So building resiliency skills, which include, for example, positive self-talk, realistic problem solving, grieving the loss of the former self, building optimism, which is highly associated with less disability and better quality of life. So it's really confronting the negativity in our thinking, because let me give you an example of the stories we tell ourselves about ourselves color our perception. If you have two people who are sitting in front of you, one person works 40 hours a week and one person works 80 hours a week, who's less stressed? Who would you think would be less stressed? Many people say the person who works 40 hours a week, but here's the deal. The person who's working 40 hours a week is telling themselves in their mind, their self-narrative is, this job is horrible, I'm no good at it, I can't wait to get out of it. The person working 80 hours a week is like, this is what I always wanted to do. This is my passion. I can't get enough of this. Do you see the difference? The stress is what we tell ourselves about ourselves. If I say to myself, I've got Parkinson's, I'm done, well then, I'm not going to do much. But if I say, like Viktor Frankl talks about, the psychoanalyst who survived 3 years in the concentration camp, if I could say to myself, I have Parkinson's, and it stinks, but I can do many things to make my life more fulfilled. That's tragic optimism, right? Based in reality, but the idea of responsibility and working with any resistances we have to taking responsibility, right? I mean, it's one thing to say to take responsibility; it's another to take a look at the things that hold us back, and that's part of being human. We have ambivalence, right? I have some people I see who say to me, I just not motivated to go to the gym. And I say, why are you waiting for motivation? They go, what do you mean? I say, well, if we do motivation, here, I'll use my hand to do it. Motivation equals action. Motivation leads to action. I flip them around. Action leads to motivation, right? If I'm not in the mood to get to the gym in the morning, that doesn't mean anything. That's just a passing thought. The right thing is to get up and go. So if I take the action, then I work out, and I go get my plant-based diet food, right? And I do all that, then suddenly I feel motivated. But if I wait until I feel motivated to get up and out, that'd be a long time. So it's not motivation leads to action, it's taking action leads to motivation. And that's the kind of thought process that we examine when we do learning to dispute the inner critic, learning to understand what our assumptions are about what we're thinking about our illness, and developing clear self-talk, more positive self-talk, self-compassion, and putting ourselves in situations like when I'm at my boxing, do that 4 times a week. And when I'm at the boxing, we have a tremendous connectivity that raises everybody up, and the shame level for any of us is way down. The power of connection is the antidote to grief. To shame. Next slide, please. Final thoughts. The final battle of illness is for the high ground of emotional health. To accept limitations, pursue wellness in a personally meaningful way, to re-engage the tribe with self-acceptance. So see, even if the tribe, like let's say I'm with a bunch of my colleagues and everybody's fairly healthy and I'm dealing with my Parkinson's, I've re-engaged the tribe because if I'm feeling self-acceptant, then I'm not going to be, if I'm not feeling self-acceptant, I'll project that into the crowd that they're going to feel the same way about me. They're not going to accept me. But if I have self-acceptance, I don't care what anybody thinks. And that's the way out, is through self-acceptance, using all the tools of therapy, of PT, of OT, of support groups, all the things that are eating a plant-based diet, of making sure our sleep issues are addressed best we can, making sure our social life is as full as it can be, because that is correlated with slower progression. Looking at the idea of supplements for nutrient, and looking at medicines and taking care of that as well, dealing with getting the medicines we need. Richard Cohen was a TV producer, and he wrote a book called Blindsided, Living a Life Above Illness. And what he'd said was, making my peace and seeing that level of comfort mirrored in those who matter the most are what the journey is all about. My family takes its cues from me. My children are learning important lessons about life. The people are not perfect, against the social norm. And some of us need help. Yes, that's a positive. There's a power in needing help, because you're giving other people an opportunity to be competent and able and supportive, and that they grow from that. And we grow from letting other people help us. And that's tough for a lot of us. It was for me. I really kept my revelations about my Parkinson's pretty undercover. That's why my score was so high on that spark, but it came way down that score after doing the work I needed to do to address the fears I had about not being accepted. That was being projected from me. What you find out if you do what they call experiments in cognitive behavior therapy, you tell people to go do experiments, talk to one person about your Parkinson's. Pick the person you trust the most, start there. And they do it, and they come back and they find out, they didn't think I was a burden. They all the things, I'm going to be a burden if I tell people, I'm going to be too much, I'm going to lose control of my life if I tell other people. Those are all assumptions that have to be examined, because many of them are not correct. It's just our fears kind of propel those conclusions. Okay, next slide, please. Man is and always remains capable of resisting and braving the worst conditions. This is Frankl. A person is free to shape his own character and is responsible for what he may have made of himself. And the other quote I like from Frankl is everything can be taken from a person except one thing, the last of the human freedoms, the ability to choose one's attitude in any given situation, to go one's own way. And I really think that's wonderful. Next slide, please. These are just some good reads. You can check this out on your own. But I'll tell you, the trauma of everyday life. The trauma of everyday life is wonderful. The Man's Search for Meaning is the first book I would ever tell anyone to look at. Heal Thyself is wonderful. And A Short Course in Happiness After Loss is really very interesting. Talks about the magic of and instead of either or, and, like and meaning like I am really upset about my Parkinson's every day, and I go to the gym, and I eat well, and I join in with people that we bring each other up, and post-traumatic growth is the idea that we don't just bounce back to baseline like resilience, but we go further. The quality of our life changes. We have deeper relationships. We get tougher psychologically, because if we can deal with Parkinson's, we can deal with anything. So there's some post-traumatic growth things that show up if we do the work. Okay, next slide, if there is one. I think that's it. Okay. So how are y'all doing?
Great. Thank you for that. I had a comment, but I also have a question. And then we can open it up to others too, if they'd like to have if they have any questions or comments.
Yeah, if they want to put their
If you want, you can also type in the chat if you have questions, if you don't want to unmute, and we can read them out loud as well. My comment is, I really like how you brought up the fact that you exercise with the community. Lisa and I run PD Connect. If you don't know who we are, we teach exercise and education for people with Parkinson's. But first and foremost, we love to advocate being a part of a community. So we always talk about doing exercise, doing what makes you happy, but having a community on your side is also something that's really helpful. So thank you for mentioning that. And then I did have a question, and maybe some of you here might resonate with this, but there are some people that we know that haven't even told their families that they have Parkinson's. Do you have any suggestions of how they can tell their family? You kind of just mentioned on that last slide, telling the closest person to you and then realizing, oh, they didn't, that they took that pretty well. And then telling the next closest person. Is that kind of what you suggest? Or do you have any other suggestions for those who are just terrified to tell their friends and their family?
I appreciate that. It's understandable, the terror, because we have a definition of ourselves that we've always had, right? We've always felt a certain way in our bodies. We've got a narrative about ourselves, about who we are. And we have an assumptive world, right? A world of assumptions. It's kind of like the idea of, letting go of all that and taking the risk to be vulnerable, right? To try a new way is very intimidating, right? So that's why we can't do it on ourselves, right? Like I had a training analyst. I'm trained as a psychoanalyst as well as a CBTer and et cetera. I spent a lot of time in school, for God's sake. But anyway, I really found that my training analyst, right, who trained me in my 4-year program after my PhD, he really helped me. He was my therapist, and he really helped me come out about my Parkinson's. It took me a long time. I mean, I told my immediate family, my wife and my son, but I kept my friends, and I look back and I go, what was the issue? Well, it was a bit of shame, because I'd always had a self-conception of myself as a strong, directed, highly motivated individual. Okay, that's my deal. And what I found is my fear was that they wouldn't see me that way anymore. That if I told people, then number one, if you tell somebody about something like this, it makes it more real when you see it in their face. Right? It's one thing to keep it in our head and it feels safe at some level, but it's another to you really tell somebody, whether it's a therapist or your PT or your OT or whatever, you tell somebody, it makes it more real. So then you got to deal with the grief of not being who you thought you were. But the beauty of it is, I can guarantee, having worked with people over 35 years and almost exclusively PWP in the last 4 years, is that people are much more forgiving and much more willing to be supportive than we'll ever know. Because our fear, we're afraid of rejection, because we legitimately, we're outside the social norm in a certain way, right? Of the so-called healthy core. But the bottom line is, once we start telling one person, and then we get the reaction we didn't expect, if they're a good and mature enough individual, they'll be like, I'm here for you. They'll be like, oh, I've got nerve pain, or I've got cancer I'm getting over. I mean, it's just like, everybody has stuff. It's just when we get our diagnosis of Parkinson's, we feel like we're the only one who has the stuff, the bad stuff, right? And then you realize it's kind of called systematic desensitization, right? You pick one person. And if you can't do that, you start with the therapist and you say, basically, like I'll role play with people, right? I'll say, well, you're not ready to tell your friends. How about you tell me what you would tell them? And we'll go through what it would be like and we'll warm you up, right? So it's really the way to go, which is to really pick a counselor or pick a trusted community group leader or pick somebody and with support of, even if it's a spouse or a partner or a care manager, start with reaching out to somebody, even if it's your doctor and you got a good doc, but I mean, not just technically, but a healer, somebody who can really emotionally get to know you, right? And know that you're more than your diagnosis. You're a complete, complex human being with all the wonderful things you've done, the wonderful work you've done, the relationships you've had, makes you a complete individual. So I'd say the way to go is to take the risk and find a safe person.
Great, thank you.
Yeah.
There's a few more questions in here. I have another comment. I just wanted people to know we're actually on the staff of PD School, which is where we met Kimball. The next question is, you mentioned a plant-based diet.
If you're, hold on.
Right, I'm segueing into
okay.
that. I'll get back to the other one. Thank you, Lisa. You mentioned a plant-based diet. My doctor hasn't suggested this. Does this research indicate that this is helpful? And Lisa, we can send you something that would help, but also, doctor, if you'd like to comment on that for us.
No, you bet. Yeah. What I was convinced, or how I was convinced, is I read everything I could get my hands on. I guess the websites here I'm going to mention a little bit, but what I would do is familiarize yourself with the research, and you don't have to go into some journal that's so abstract you can't get what's going on. There's a couple websites that Lori Mishley has that explain all of this in great detail, right? In other words, she has a, let me see which one it is. Oh, Parkinson-school.com, Parkinson-school.com. She has a 24-course video series that has it all stuff about food and supplements and medicine and everything you'd ever want to know, sleep issues. My God, I can't think of them all, but there's 24 of them, and the videos hit every aspect of Parkinson's and what you can do in a practical, level-headed way. And plant-based diet has been shown to the different, plant-based diet is correlated with a slower progression. And she's got that research that shows that. So
yeah.
I've been committed to that for 8 years, actually.
I have a question about that, because we have actually been, for the last 3 years since we were on staff with Dr. Mishley, been advocating for a plant-based diet. But just like we advocate for exercise, how do you, we talk about resilience and unbreakable, what does it take to transition to that? How do you say to someone, oh, well, I don't want to give up my cheese or my steak, my ice cream. Yeah.
That's a great question. I can tell you what I think. I'd say a couple things, but I say, like, I have PWP. I've shared it with them, my buddies, from boxing and from community groups and stuff. I share the research, and the research isn't like, BS research. I mean, this is good, hard-nosed research she's done, and she's really kind of the cutting edge. Lori Mishley, she's the cutting edge in this whole alternative treatment approaches. And bottom line, I would say to somebody, if they said, well, I don't want to give it up, I would, of course, as a psychologist, I would say, I'd explore. I'd say, what's holding you up? And what do you think they'd say? Lisa or Steph, what do you think the person would say if you said, what's holding you up from making the commitment to something that's proven scientifically to be really helpful?
I don't think I can do it. I mean, what about I'm not going to get enough protein? And
for 70 years, I've been eating ice cream every night.
I must be,
I'm fine.
I'd rather eat ice cream than
Than do all the stuff. Well, you know what? I appreciate that you really don't want to let go of what you've known, because it's scary to let go of the comfort and the security of what you've always known. So maybe you should talk to me about how hard it is to let go of the security of what you've known, because if something is proven to be healthful, then it must be more than you just don't like ice cream. It must mean you don't want to give up ice cream. It's something you're protecting in you, a security that you feel around what you've always done. And maybe the idea of thinking of transitioning to something different is a bit scary for you. Can you tell me about that? And then I
Good. Yeah.
Wow,
they call that exploring the resistance. See, we all want to do something, and then we have an equal force that says, don't do it. Keep with the familiar, keep with the secure.
Right.
It's
Excellent.
like when I was thinking of telling, all my colleagues that had Parkinson's, I was like, I had an equal force. It was going, nah, you can put it off. Nah, don't sweat it. Nah, nobody needs to know that. Nah, then you get to a place where you work through the ambivalence, and then you go, yeah, I'm game for that. I mean, I remember when Dr. Mishley told me, when are you going to give up that cream in your coffee? You got everything else done. And I said, oh man, you're right. So what happens is if you establish a relationship, whether it's a nutritionist, a psychologist, somebody wonderful like Dr. Mishley, whether you all who run your nonprofit and do so many good things with PT and emotional support, I mean, you just turn to one person and start exploring and examining, because self-knowledge is power, man.
Absolutely.
cool.
Thank you.
That's an awesome answer.
Well, let's get back to the topic really, which is we were talking about shame and whatnot. And another question is, if you're single and dating, at what point should you tell the person you're dating that you have PD?
Well, I think this is one of those, it depends, because this is an individual decision, and it should be guided by what your expectations are for the relationship and where are you in the relationship, right? So, for example, if you just met the person, depending on, I mean, there's some people who would say, oh, I just so you know, I have Parkinson's in the first or second date, and that might have a certain effect, right? And then some people take their time and want to build up some trust, and you don't owe it to anybody to reveal, to disclose. It's a part of you. When it's just like any other part of you, you need to feel. I believe people need to feel trust, and they really know somebody and really feel comfortable with them. Then they can talk. Then if you think about it, Parkinson's is like anything that we think is a little taboo in our culture. You don't bring it up immediately, but most people find that they put their finger to the pulse, and when the trust level is high enough, if the person or you're going to talk to is mature enough, they'll take you as you are completely. Now, not everybody's like that. I mean, some people don't run as deep. Other people run deeper and know that we're all in the same boat. It's just a matter of time when we're going to get some crap to deal with, right? Everybody's in the same boat. I always tell people that. So anyway, so my point is, it depends on the quality of the relationship, depends on what you want out of the relationship. If you want commitment and you're looking for a good partner, right? You're going through that stage where you're dating and meeting all these people and you want to find a good partner is somebody who can deal with the good and the bad of life. That's my opinion.
Cool. You mentioned it really briefly though. Can you also talk about post-traumatic growth? Because that I think is just fascinating.
Right. Yeah. You know what you can do now? It's so great. You can just Google post-traumatic growth, and the guy's name is Tedeschi, and what's this other guy's name? Well, it's Richard Tedeschi, and Lawrence Calhoun. And they just did the last couple of years. They've done all this research on post-traumatic growth, and Seligman at the University of Pennsylvania also did a lot of work on, resiliency and post-traumatic growth. But Tedeschi and Calhoun, you can get all their stuff. They're really the best. Richard Tedeschi, Lawrence Calhoun. You just put their names in under post-traumatic growth, and you get 2 or 3 great articles. They're not all real wonky, boring research stuff. There's summaries of all the research and what the 4 or 5 measures are of post-traumatic growth. And actually, I'm going to a workshop online on Friday on post-traumatic growth, so I can get back to you about some of that stuff too. But the articles are really terrific. And what the bottom line is resiliency is going back to baseline, right? Bouncing back. If you define resiliency, it means bouncing back. Post-traumatic growth is if you let yourself grieve your diagnosis, work your way through that, learn to recognize your emotion, learn to understand and verbalize your emotion about it all. Then you'll find that you heal up, and then you have energy to do other things that you wouldn't have done before. So the difference between resiliency and post-traumatic growth is going beyond coming back to baseline, but going further. There's a difference in quality with you. For example, people who have post-traumatic growth, and anybody can have post-traumatic growth if they work at it, but post-traumatic growth is the idea that you're qualitatively different. You're not just back to baseline. And examples of this are people who have post-traumatic growth are much more willing to and able to prioritize how they're going to spend their time with people, because they realize that this is serious business. So they need to really invest in people who are going to really give them back good connection. Post-traumatic growth is the idea that if I can deal with this, I can deal with anything. So there's a psychological strength that comes through. Post-traumatic growth is people doing new things that they wouldn't have done before. They didn't just come back to baseline. I know this one guy, he volunteers running all these fundraising things. He never would have done that before. He's helping hundreds of people. And he has a passion now because he has Parkinson's. It's like, hey man, I got to deal with this, and I want to help other people deal with this. Post-traumatic growth is you recognize that your relationships with the people you love are really, 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 really important. So you get deeper in your relationships because you've been through the fire, right? And you've come out of the fire stronger because you grieved and dealt with it. And then that energy is freed up after the grief is passing. And then you're more willing to do new stuff. I mean, I wouldn't have been boxing 4 days a week. My God, what am I, nuts? 4 days a week? So I enjoy it. But the connection I have with my friends, I wouldn't have met people like I meet. I wouldn't have met the people that I've met, right? The friendships we forged, the depth of the connection, that's healing in and of itself. And that's one of the things Dr. Mishley's research shows, is that isolation, is correlated with progression, connectivity, and, being very connected to fellow PWP and your other friends. It changes it's positive, and it changes your relationship with the friends you already have once they get over the diagnosis. I've had friends who say, oh my God, I'm so glad you told me. I'm dealing with this. And now I feel like I can talk about it because you're talking about it, right? You can spur people on to stretch themselves emotionally and become even a finer human being. That's what Viktor Frankl, the psychiatrist, says. He says, out of our pain, out of our suffering, you can form meaning out of the most miserable circumstances. He was 3 years in a concentration camp, and he ended up he said the people that survived were not the people who were physically the biggest and strongest. It's the people who found a meaning in the camps, right? Thinking about maybe a spouse that they would see if they got out. He used to think about a book he was going to write, which he did. He would write the pages down in his head. He would make the story up in his head, the book. So there are many ways to find meaning, and that's what post-traumatic growth is all about, is going beyond just bouncing back to normal. It's about getting deeper. And dealing with the Parkinson's allows you to really open up to people, and you realize you're not the only one who suffers.
Yes, thank you.
Oh yeah.
So we are running out of time now. Does anyone have any last questions related to the topic that they'd like to ask?
Nice being with y'all.
It's great having you and being with you again. It's been so long since we've seen you.
Oh, it's so great to see you guys. Thank you so much for inviting me to be able to be with such a wonderful group.
Of course, we were excited that you said yes, and we were just explaining earlier that we thought we should have him come talk in 2019, and then then
August 2019. We've been thinking about having you come on to talk to us. So thank you.
Thank you very much.
It's a mutual thank you. You got it.
Right. Well, we appreciate you being here, and we'd love to have you come back and talk some more another time. And Lisa, is there anything you want to do to wrap it up? For those of you who don't know us, we're PD Connect, and we teach exercise and education for people with Parkinson's. We'd love to have you join us anytime. Our classes are all virtual or in person if you're in our area. But anyway, thank you again so much. We try to cover a huge basis and I know you've got a lot of questions, all of you, about other things. Check us out, follow us, do all of those things, join our newsletter. We're pd-connect.org. And hopefully we can get you some of those answers you're looking for. Thank you so much, Dr. Magoni.
Thank you, Dr.
Appreciate
Magoni.
seeing
Thanks
you.
for staying. It's dark out where you are now. I know. We appreciate you staying up for us.
Yeah, I'm just gonna go eat
out here.
Yeah, I bet. Time to eat my second lunch.
Thank you so much, you guys. Really wonderful.
All right. Thank you so much.
Bye. Take
care.
care. Thank you.